I think we're live.
We are live. Hello, and thank you to everybody who is tuning in to my conversation today with Kathy Moreland. Before I get started and introduce you folks to our particular topic of conversation, I just want to begin with a land acknowledgement. We are having this conversation. I'm hosting it from my home right here in Kitchener. And this land has been held down, cared for, loved, and stewarded by the Haudenosaunee, the Anishinaabe, and the Neutral people. And as many people have heard me say in the past, one of the most important things about a land acknowledgement isn't, the first step is acknowledging the land. The real work comes when we make a connection between the reality of that land acknowledgement, what that means to us, and the conversation we're about to have. And for this morning, my conversation with Kathy is going to be some real talk about what public health nurses and experts have called a public health emergency within a public health emergency, and that is the opioid crisis. For a lot of Indigenous communities, the realities of having to navigate ongoing colonization has led to various people reaching out to different coping mechanisms. And people don't actually always understand or interpret addiction as a way that somebody has asked for help, or a way that somebody has navigated feeling alone or feeling like they don't have access to the supports that they need. It's why there's such a big cry in community to see addiction as a health crisis as opposed to something that needs to be policed. And I think it's really important for us to just take some time and have some real conversations about what it is like to navigate the opioid crisis on real terms in our families. Far too many of us have experiences of this and don't really want to talk about them because we're made to feel embarrassed. And I think that now is the time to take away that stigma and have some real talk with MPP Lindo. So again, I am Laura Mae Lindo. I'm the MPP for Kitchener Centre, and I am joined today by the lovely Kathy Moreland. Kathy, thank you for joining me.
Thank you for having me.
Kathy, you are an RN in town, right? In Waterloo Region?
Yes, I'm a registered nurse, and I'm a professor of nursing. So I've been a nurse for a long time. So I'm not in the front line, and I would like to take this opportunity to acknowledge my colleagues who are in the front line and working so diligently and so hard to try to contain this virus. My hearts go out to them. So I'm one of the fortunate ones who's staying home to try to support my colleagues. Yeah.
Well, and as much as I get the front lines and who's at the front facing of navigating the pandemic, but the reality for me, at least in the conversations that I've had with local health experts, the job that you're doing when you are teaching, whether it's new nurses or talking with your colleagues about ways that we can navigate, or sharing experiences of, I've had doctors and such reach out to me and say, this is what we did during SARS, and we're not doing this during COVID, and we need to make those changes. I, in my heart, see you as part of those front lines, because it takes all of us, right?
I think everybody has their part to play, and that's probably a topic for another topic
for another conversation.
Yeah.
But part of why you were introduced to me just the other day was because I was having a meeting with the RNAO in town, and we were talking about the rise in overdoses. And in fact, yesterday I did a live discussion with Sandy from the CEO at One Roof, and she was talking to me about youth in town, the fact that many years ago, she was looking at maybe an overdose every couple, I don't think it was definitely not daily. It was like, you'd say every couple weeks there would be an overdose. It was not something that was as common as she is seeing now. And so there've been a number of people who have asked for, like, what is the government doing to support? There's all of those kinds of conversations, but there's also questions about what it is like for folks to navigate, and what kinds of supports people wish were in place. So your name was, you were introduced to me through that meeting, because you're not only on the front lines doing this work, or, you know, as you were saying, supporting your colleagues who are on the front lines now, but you've got a personal connection and understanding of what's happened during this crisis. And so I want to just sort of throw it over to you. You can take this conversation anywhere you want us to go, and just lots of love. I'm sending you so much love through this technological medium, and just grateful you're going to share with me.
And I hope I can get through it without, I think I have to put my nurse face on versus my mom face right now to try to share this. The reason I was introduced to you is that unfortunately I lost my son 7 months ago yesterday to a fentanyl overdose. He was 18 years old. He had just turned 18, and the day before he overdosed, he had just finished completed his high school preparation and was on top of the world. And we, as a family, struggled for 2.5 years with his substance use, which came about through him self-medicating for severe anxiety. So the whole issue of substance use is so complex and so stigmatized in our society that there's this idea that it's poor parenting or that it's a choice. I don't believe Austin. My son's name was Austin, and Austin and I never sat down and planned his future career as being someone with a substance use disorder, and it came about quite innocently through experimentation with friends, and he liked the feeling because he had had years of mental health issues associated with his he was born with fetal alcohol spectrum disorder, and so he had severe anxiety that really didn't respond well to medication or anything like that. And he was also segregated from a lot of his friends because he had a really difficult time being in a regular classroom. So through wanting to belong, which is considered now to be one of the main sources of substance use, and wanting some relief from his anxiety, he started experimenting with different substances unbeknownst to us. He was very good at hiding it. And then when it became obvious, I would say 3 years ago, he was introduced, unfortunately, to a number of youth in our downtown core who used methamphetamine, and that just took us all on an amazingly painful roller coaster where I learned. I had already thought the mental health system was complex for youth because just if I back up a bit, Austin had been removed from school and could not return because his anxiety would sometimes show up as aggression. And he was removed from school, and we were told under the Safe Schools Act, we were told he could not return to school until that wouldn't happen again. And we had him home for over 6 months with little, if no, education support, and me trying to work as a single mom, waiting for a bed at CPRI, which is in London. And I was very fortunate to have good friends. I have no family here in Kitchener. I had good friends who would watch him while I was teaching, and then thankfully my work can be done from home, but was very difficult to do, as you're learning.
Of course.
Very difficult to work when you have a child in the house who was needing a lot of attention. Anyway, so that had been complex. And, when Austin finally did get into CPRI, I was told I was lucky because it had only taken 9 months to get him there.
And that was considered lucky?
Well, I was lucky because for most kids, the average wait time for residential youth mental health services is anywhere from 18 months to 2 years. So you have parents at home struggling to try to balance whatever normal is for them with a child that may or may not have access even to a psychiatrist. So the whole mental health system, and when we start talking about mental health and access, both the former government and our current provincial governments will throw millions of dollars at it thinking that that's going to help, but it's like throwing crumbs to starving people because the last I think the last amount was just over 4 million. And I said, but there's over 400 mental health agencies in Ontario, which means that $4 million probably maybe would cover one FTE for each of those agencies, which, when you're got children waiting 18 to 24 months for intense services, it creates a whole chain reaction of problems. So you've got the family distress there, you've got a healthcare system that is becoming demoralized by not being able to provide the service they know they should be, which then puts up the walls, which then creates a lot more. It just perpetuates itself.
And that's something that Sandy had brought up yesterday when I was speaking to her, that with young people, like with many other people, but young people in particular, when they finally say, okay, I'm ready for help, that help has to be there.
Yeah, and that's a huge issue in substance use disorder. So my work with the RNAO,
that's my little one. Sorry.
Go ahead.
Don't know what group I am.
You're in group 4. It's okay. Just say hi. You're live on Facebook and on YouTube. Okay. Wave. Okay.
No,
Go
I'm
ahead,
on
Kathy.
YouTube.
That's okay.
Yeah, you are. Okay.
Thank you for being quiet. So your mommy and
Did
I
you hear
can
that?
talk.
What?
Thank you for being quiet so that we can talk.
Yeah.
Give
You're
them a
welcome.
thumbs up.
You're welcome
What are
to.
you doing?
We're doing a video. I'm
For
talking
what?
to Kathy.
Are you talking to Sarah?
Zara is there too, but that's behind the scenes. Okay. Mama's going to finish. I'll be done soon, I promise.
No.
Okay. Go ahead, Kathy.
I understand. Trust me. So when I'm pretty well versed as a parent and as a nurse in the select committee report from 2010 on mental health, and you were talking about youth services, and so all of these services. The sad part is that when upstream thinking in public health is that you look at what's causing the problem. So if you look at trauma-informed approaches to substance use disorder, it's around caring for children, preventing adverse childhood events. Sometimes it's just creating possibilities for marginalized youth who may or may not come from troubled homes. So all of those children, all those young people you see downtown, some of them don't come from troubled homes. Some of them have great parents, and these kids, through just the luck of the draw, have ended up sort of going off and doing experimenting or getting into trouble. And once they get onto the streets, and my son was part of that, once he started hanging out with these young people are easy prey for drug dealers and criminals who just like trafficking, they woo them in with promises of friendship and status and all of this stuff and get them involved. So the whole issue of substance use is a quagmire of issues of mental health, community support, policing, criminal justice, and healthcare and social services. Like, it's just a big mesh. And I think, when you look at what the findings of the select committee in 2010 on the road to wellness, for example, the road to wellness in youth, in mental health and addiction, those findings from that report that is now 11 years old are still ever more prevalent. But what's made it different is that the drugs that are out there are so much more lethal. It's kind of like the gun debate right now, where when in the States they just had muskets, right, that could barely hit the side of a barn, and now you're dealing with military AK-47s or things like that. So when you and I were younger, the drugs that were out there, they could be dangerous, like cocaine and heroin were out there. But the stuff that's out there now, 1/4 grain that you can't even see on the pin of a head could kill somebody. And because of COVID, it's gotten even worse. So in our region, 97 other families in our region are going through what I'm going through. They're having their hearts ripped out, having lost a child, no matter what their age, have lost someone to this horrific, what I'm calling syndemic, because it's gotten worse because people, the shelters have been moved to further away from the safe consumption site. The drug supply has been cut off because of the border. And so people are making stuff in their basements that's so lethal. And, you know, that doesn't negate the responsibility of someone who is struggling with substance use, that they are ultimately the one who consumes that substance. And so people are looking for me to blame someone. And I say, well, ultimately, my son knew of the dangers. But even the week before he died, he said to me, Mom, you don't understand. He was really doing well. He had been, I thought he wasn't using anymore, which was kind of naive of me when I realized that he had no access to treatment because of his FASD. That's a whole other topic that you and I will probably talk about. And I am talking about the ombudsman, about when he wanted residential treatment for fentanyl abuse or fentanyl use. He was denied treatment as soon as I said that he had FASD. We don't take people with FASD. And yet that's one of the highest risk groups for substance use because of their impulse control issues and their anxiety issues. Like 85 to 90% of people with FASD have anxiety and depression issues, like mental health issues. And this was, he said, Mom, you have no idea. He said, I'm trying so hard not to use because, but he said, try to imagine the best food you've ever eaten in your entire life and multiply that by 30,000. That's what it feels like when I use fentanyl. He said, it's like an angel hugging you.
And this was just a week before.
Yeah. Because he as a harm reduction strategy, I was allowing him to smoke pot, and which I never thought I would do in a million years. But as a parent, I was trying so desperately to find something to help him with his anxiety. So certainly COVID has complicated access to mental health resources as well, because for some people, online just doesn't cut it. Yeah. So, and even my daughter, who's 21 and also has FASD, we've put in 2 referrals for psychiatry for her. And both times we've been told they're not taking any new clients. And she has major anxiety issues and conversion, especially now since Austin has died, because he died at home. And so, he arrested at home. He was resuscitated and died 2 days later, but never regained consciousness. But she was here when that happened. And so the trauma for her has been indescribable. So there's follow. So it's just that's why I say it's this quagmire. And as a region, I think we're probably further ahead than some other regions in terms of having discussions. We have a police force that really is looking at harm reduction. And I mean, I've had many conversations with police officers, and their hands are tied because the criminal justice system is telling them not to lock up these people because locking them up doesn't solve the problem. I've talked to the Crown, and they won't court order treatment because there's no facilities. And so when you say that the head of A Ray of Hope is talking about accessible services, that's exactly it. So you get someone who's struggling and knows what this is doing, and there's that cycle of shame and use and numb it, and then risking death every time they use. They know that they're risking death every time they use, and yet the compulsion, I always say, the only thing I can liken this to is when a bag of chocolate chip cookies is opened, for the compulsion for me not to eat them. And then I try to imagine the magnitude of desire for someone who's struggling, whose brain has been changed by substance use, because it is a brain disorder, right? It changes the brain. And there was just, so you get someone come into an emergency room who says, I'm ready, I want to quit, I'm ready. Well, there's no beds in detox.
Yeah.
So they like, here's the number for detox, keep calling them every day. Well, I sold my cell phone because I needed drugs. So I don't have a cell phone, which means I have to find a place to keep that card because I may be on the street, or even if I'm living at home, I don't want my mom to find this, or I don't want my wife to find this. I'm not just talking about youth. This is an issue for people who are functioning individuals with substance use disorder, and that includes alcohol, who function but live every day with the shame and not wanting to do what they're doing. So there's no beds of detox, and then even once you're in detox, there's very few funded beds for treatment. If you want to pay, like I was willing to pay for my son to go into youth treatment, but was told, and that was like tens of thousands of dollars that I would have had to have paid. But then was told as soon as I said FASD, they said, well, we don't take people with FASD because that affects their numbers, I suspect. They're
Well,
not
and
successful in consequence-based treatment, right?
And I think that this is part of that broader conversation that is now coming to my office, that on the surface, yes, we know that we need to provide support to folks. And the government on the surface says, okay, we're going to provide additional funding, as you were saying earlier. But when you dig a little bit deeper, just one peel of that onion, you realize that the issue itself is far more complex.
Oh,
right?
Absolutely.
Far more complex.
Providing so when part of what I as an individual and myself as part of the Registered Nurses Association, what we look at, because we see it at the front line, and I see how it demoralizes my colleagues and how helpless they feel, which then leads to the stigma, because it may surprise you that most nurses don't have any education on trauma-informed approaches to care. It's basically very sort of that perception that people who use substances are weak, and that they make this choice and that's it. And I say to anybody, who amongst us didn't do something stupid when we were younger, and then realize like we shouldn't do that again?
Yeah.
Whereas someone who's pre-wired for substance use disorder or addiction, they get on that slippery slope and they can't get off, because it just and that's the problem. You can't always predict who would be at highest risk. So, and it's not a disease of the poor or the marginalized or the poorly parented. It happens to everyone.
Yeah. And so in my office, a lot of people will reach out seeking supports, etc. And part of my role as the MPP is to try and find ways to encourage community to plug into some of the advocacy that we have to do to make the change, right? And so just if we had an opportunity to do some petitions and ask for proper resourcing, is there something in particular that we could be asking for that you think would actually make a difference for families like yours to be able to provide proper support? Like, my mind immediately goes to, should we be advocating for trauma-informed nursing or changes to the curriculum for the nurses that are coming out? Is there something else that I should be advocating for so that I can start doing that work?
Well, that's a complex question in itself. So certainly the College of Nurses has already included trauma-informed care as part of our standards practice. So, and even the Road to Wellness document that was introduced in the legislature last February or March includes the fact that frontline people need to be educated about mental health and substance use disorder in a more informed way. So certainly that has started at Conestoga College. We've already started bringing in people and it's eye-opening for students, because the main thing around trauma, if someone who's watching this wants to know, well, what's the difference between what we do now and what trauma-informed approaches is? If someone came in with something that is actually really self-destructive, our usual approach is, why are you doing that? Or is what's wrong with you? You shouldn't be doing that. Whereas a trauma-informed approach would start with the question, what happened to you?
Yeah.
Which means that, because there's research out of Harvard that shows that adverse childhood events are the main contributing factor, not only to mental health issues and substance use disorder, but chronic illness. When they take out all other factors, adverse childhood events contribute. So to go upstream, I would say what we should be advocating for is appropriate care for children.
Yep.
And support for parenting and support for, you know, for early intervention in mental health for children,
Yeah.
and creating connection in community, as opposed to the old thinking was, you know, let them hit bottom and then they'll like, and I say to people, so if you hit bottom and then you go, okay, I've hit bottom and I need support, there's no support there. So
Yeah.
not only do we need support, because people will say, well, there are programs, they need timely and financially and physically accessible treatment. So that means if I decide, like if someone walks in and says, I have cancer, yes, there's that wait period of getting, getting your staging done and all that, but your treatment starts immediately,
Yeah.
whether that's even the screening. So if someone walks in and says, I have a problem with drugs or I have a problem with alcohol, they should be able to get treatment right away, not say, well, I'll detox every day and see,
Yeah.
there has to be some alternative. And so my first, if you're saying, what do I would want the community to advocate for, is compassion, for one. Instead of thinking that these people are pariahs of
Yeah.
our, they are to me the end result of our ignorance, and they are the most vulnerable and the most marginalized amongst us. And because it covers all races,
Mhm.
all economic groups, and ages, but our youth in particular are left to fend for themselves. Group homes are closed. There's
Yeah.
no, and even group homes are the most difficult of the most difficult, end up there, and they don't have a lot of support, and they're allowed, I don't know if people are aware, but our shelter system, the children are allowed to sleep there, but they must leave by 8:30 in the morning. So they're left on their own all day and cannot return. The ones under 16 can return at 5 o'clock, and the ones who are older than 16 are left to fend for themselves until 11 o'clock at night.
Yeah. Yeah.
So what do they do all day?
Yeah. And so this becomes that perpetuation of the problem.
Perpetuates drug use, perpetuates criminal activity and the indoctrination and so they don't feel like they belong, and also trafficking. The young women who are possibly fleeing abusive homes, or who just are rebellious and are thinking, like, I'm going to go out on my own and screw my parents, end up being fodder for people who, unfortunately, who I have compassion for, are the end result of that perpetual cycle of, I'm a bad person, so I'm going to act like a bad person. You believe I'm a bad person, so I'm going to be a bad person.
Mhm.
So, and it presents problems for our police force, who, I'm not, I'm very well aware of people's concerns around police, but I believe that police have their hands tied because they cannot, they are being told not to incarcerate or to hold them. I've had many encounters with police with my son, and they were always wonderful. And I don't think, do I think that might be because of who I am and, that I'm a nurse and all this other stuff? I don't know. There was always that trying to understand, but they are trying, I think, but they need more support for mental health, because many of their calls are for mental health issues, right?
So Kathy, I think that we have touched on so many different aspects of a really complicated issue.
Yeah.
And I do think that there's need for us to go into that discussion as well, around policing, around mental health, around the calls that they're getting, around what police service would need in order to be able to not be the first responders at these kinds of calls, etc. But again,
I have to interrupt you.
Yeah.
They needed to be first responders because there was physical aggression going on. So unless you're going to send me a social worker who knows Taekwondo and, restraint, this is the whole issue around defunding police. I don't think that police need to be defunded. I believe that we need to have more joint teams where there's mental health support going along with the police, like that those should be the teams going out. There were situations, like many situations with my son, that the police needed to be first on scene because
So
he was out of control. And I would never send a social worker into that circumstance unless they were trained to deal with that kind of situation.
yeah, and Kathy, I totally get that. It's interesting because whenever we do end up in a conversation around the calls to defund the police, most of the times people want to sort of, okay, let's stop and let's move on to something else. Unfortunately, I'm the lady who's like, no, let's have a discussion about what safety looks like using that upstream lens that you used,
Exactly.
right? And so when we think about upstream supports, depending on the circumstances, and as you've outlined, like everybody's circumstance and what this looks like for them is very, very different. What do those upstream supports look like? What happens to me, for instance, as a Black person in community or an Indigenous person in community, when the first person to respond is a police officer? Do I feel safe? If I don't, what could safety look like for me? And let's have those real conversations. Now, that said, I believe that is, we need to set up another time. I'm talking to the people in the back end of my conversation on my team. We need to set up a time to have that conversation. I think that we can and that we should. And I'm getting a thumbs up from Zara on my team as well.
I just want to say,
yeah, for sure.
Because I feel like I didn't answer your question. If I had to advocate for anything, ask the community to advocate for anything, it would be for harm reduction approaches. So safe consumption are only one part of it. Safe drug supply, which could probably be a whole other topic on itself, because that's like blows your mind. Like you're going to actually prescribe these drugs to people.
Yep.
That the whole idea of safe drug supply and accessible treatment and all these things, what we should be advocating for, safe consumption sites save lives. And to me, I don't have that hope anymore. My son is gone. As long as someone with substance abuse is alive, a substance use disorder is alive, there is hope that they can turn their life around. And I know my colleague, Christina, has shared with you, in one day, she works at a safe consumption site. In one day, she reversed 8 overdoses. She saved. So that number 98, that's 98 families who have been impacted by a lack of service and a lack of treatment for substance use disorder. And am I naive enough to think that, yes, some people are always going to die? Yes, of course that. But we put seatbelts in place because we knew that people could die in car accidents. Yep. And still some people die, but we have saved so many lives. These harm reduction approaches are the stopgap measure to keep people alive so that they can get to treatment.
That's right.
That's what we need to shift our thinking. When people don't want them in their neighborhoods, I think they have to realize they're in your neighborhood anyway.
They're there. Yeah. Yeah.
They're hiding needles in your backyard, in your alleys, and in our streets. Yeah. At least a family like mine can be. I know my son accessed a safe consumption site in downtown Kitchener, and I am so appreciative because they probably saved his life. He probably would have died much sooner. And other than bubble wrapping him and duct taping him into a steel room with a lock on it, there was nothing I could do as a parent to stop what happened. I know as a parent, I did everything humanly possible to save my son's life.
Yeah.
And people need to stop the stigma. These people need help and they are wounded. Yeah. And our care of them is a reflection of our compassion for humanity, these are not the undesirables. Their behavior is often undesirable, unfortunately. Stealing, lying, those are all symptoms of the disease, not the person. So,
Kathy, listen, I want to say thank you for sharing and being so open in your discussion. And I want to say thank you to Austin, to be honest, for,
that's him.
I just want to say thank you because honestly, you don't have to share the story and you don't have to do the advocacy that you are doing, but you are, and we as a community are stronger because of it. So just, I'm sending you loads of love. We're going to be in touch, because what I am going to do on my side is try and create sort of like a petition that we can circulate in community to talk about what some of those upstream supports, more concrete supports, can look like. And before you know it, I'll be back at Queen's Park, and I will bring some of these concerns there as well.
I'll just say this one thing. As supporting harm reduction strategies does not mean you condone drug use. It means you embrace the reality that it's happening.
Yeah.
And that lives are worth saving. So most of us know that those things that we grow from are the worst things that have happened in our life. Just think of the potential we're losing in not saving some of these people who have lived the hardest lives we can possibly imagine. And yes, I truly appreciate this. I am not ashamed of my son. He lived an amazing life, and this is part of his legacy, and I owe him that, to continue the fight, because that's what he would have wanted me to do.
Beautiful. Listen, Kathy, thank you so much. So much love to you and to your family. And thank you again for sharing. Okay.
Give your boy a hug, because that's the best age.
It's so good. And he just won his video game. And so things are moving. Okay. Yeah. Goodbye, everybody. Thank you to everybody for watching. And we are out of here.
Goodbye.